Hey, everybody. Can you hear me?
Good evening, everyone. Here we are at the Public Safety Committee meeting of the Town Council, special meeting on Tuesday, October 29th. It is 4:32 p.m. All councilors are present. In addition, we have
Mr. Kinnicky. Bert.
McDonald.
Wilson.
Our first item up is communications. Does it? And then approval of minutes. We have minutes from September 17th. You need to make additions. The first is that the motion was made, or the approved motion was made by Councilor Pacino, and it was seconded by Councilor Merritt. The second was also for adjournment, so that motion was also Pacino, seconded. Any other changes? Oh, I need a motion to approve. So we made the corrections. Any other corrections? We all approved it as amended. If that's the word I'm looking for. Sorry, it's been a very long day. As amended.
Yes.
Aye.
Aye.
So review. You mean under who was on the roll call? It's right here?
Yep.
Under roll call? Do not think that that should be in there. It's just other people present. You approve the minutes. That passes 3-0 to 0. And Mr. Holdsworth, I'm so sorry I missed you. If you want to introduce yourself, please.
Bob Holdsworth, president of the Holdsworth Group, and the author, along with folks from Groton, of the report you have in front of you.
And my apologies for missing the first round.
No worries.
So we are here today to talk about standardizing or finding a policy to standardize funding for Mystic River and the Groton ambulance. This would just be a policy. It is not that we can force with the RTM, but we wanted to make sure we're coming up with a process that would be appropriate for both. So the last time we met, Mr. Holdsworth was going to put in, presented some information, who was going to put in first and then back. I know that we just received this information, so my proposal for tonight is to go over what was put in front of us, discuss it, and then we all do look through it, give our thoughts to it at the next meeting. You're welcome to put input in tonight as well, just so that. Okay. All right. Put this, or do you want Mr. Holdsworth?
We'll have Mr. Holdsworth.
Do you want to present what we have in front of us? We just received them.
Absolutely. So I said that I would put together a document for you for perusal and discussion. This is based upon Groton Ambulance's data. I got Mystic Rivers, part of Mystic Rivers in the beginning, and I got some of their data at 2:00 this afternoon from one of their vendors. So while the concept will apply and can apply to both agencies, the data in this report is specific to Groton, but if we agree on the formula of the week, I'll discuss, in my opinion, how the same formula would be applied to funding for Mystic River, if that makes sense. And then at the next meeting or between now and the next meeting, I can put together a page that is Mystics specific application of this. So today is about the issue, because I think it's important for the Public Safety Committee, when you go back to the RTM and you go back to the full council, part of it is you need to be able to articulate to them why funding is necessary to begin with, because someone's going to ask you. So I wanted to give you some background about the ambulance industry in Connecticut and Groton specific, that would help you educate your colleagues about why a continued subsidy is going to be necessary. And then we can talk about the process by which the formula can work. So first of all, I appreciate the opportunity to do that. The way that it works in Connecticut is that EMS agencies are given a rate by the state of Connecticut. It's called a retail rate, or the maximum allowable rate. That's given to them every January, and we use that term. We say that's the retail rate. That's what ambulance services charge on face value, nowhere near what they get paid. So the state assigns the rate. The reimbursement is made based upon the number of transports that an ambulance service completes. So a couple of important things is that the ambulance has to be available 24 hours a day. So there's a cost of readiness. And that cost of readiness is the overall cost to have the ambulance service in service, staffed, equipped, with personnel available 24 hours a day, waiting for a call to happen. And we staff the number of vehicles based upon the anticipated number of calls that we have to look at retroactively to say how many calls have there been in the last couple of years, and what seems to be contracting or expanding. In your case, it's expanding. There's more calls coming in. That doesn't mean you're getting paid for all of those calls, and that's an important thing for both you and your colleagues to understand, is how the ambulance works. So in the case of Groton is requested approximately 6,000 times a year. And by requests, meaning somebody calls 911 and says, I need an ambulance. The ambulance responds to that call, and the completed transport number is just about 4,200, 4,250 was last year's. So the difference between a request and a completed call, a fire standby, a police standby, a school request, a motor vehicle accident that turns out not to have injuries, even though it was originally reported that way. A patient who refuses to go, even though a family member may have called the ambulance for them. And two of the things that are kind of really important are wellness checks and lift assists, which is something that both agencies deal with a lot. Groton, I know, deals with a fair amount of those. Again, and clarity involved, I actually used to ride with Groton Ambulance, so I know them because I used to do them. And also was a paramedic with the hospital responding into Groton, so I understand the system really, really well. So while the cost of readiness is being prepared to answer 6,000 calls, there's almost 29% of those calls, 30%, that end up not being a transport. So you have to have resources available, expend the resources, but you're not going to get reimbursed for that. And there is a movement to allow for treat and no transport. So when you get to a patient and the patient refuses, right now Medicaid is the only one that pays for it consistently, but they don't pay very much. They pay about $68, not even covering the cost of turning the wheels and getting there on it. But it is something. Groton takes advantage of it. I'm sure Mystic takes advantage of that. It's not a lot of money. It doesn't really factor into the equation yet. But it's important that you understand that they are taking advantage of every opportunity to generate some revenue, because it plays into the formula that I'm going to explain in a few minutes.
I have a quick question. That $68 is do a dry run, and it's Medicaid.
It's not if it's only if they get to a patient, render care to a patient, and the patient ends up not going to the hospital. So lift assist, it doesn't really pay for that. We've been attempting, the billing company has attempted to get that paid, but when a lot of those patients are elderly, they're on Medicare, Medicare doesn't pay for that yet. So it's only Medicaid that pays for it. And in Groton's case, say again?
If I could just interject for a second.
Of course.
So us to get paid for that through Medicaid, we have to assess vitals and we have to assist in some other way, whether that's providing a lift assist, helping them take their medication, something along those lines. And in order for us to bill for that, we have to get certain information from the patient. And the patients are now kind of refusing to give us that information because they know that they're going to get billed for it. So it's another barrier that we are forced or faced with. And it is only, I think, $60 or $68 per call. And we have 2 EMTs and the ambulance respond to that location. So it nowhere makes up for what we have to have in order to be prepared for those.
And Medicaid is actually a small, it's a percentage of your business, but it's not a huge percentage of your business, which you'll see in a few minutes. So the thing that the reason that ambulance services are looking for subsidies or in need of subsidy, there's really kind of 3 things that are kind of all coming together at the same time, and it's kind of a perfect storm, if you will. One of which is a lack of available personnel. Over the last several years, and it's about the last 8 to 10 years, the state of Connecticut's lost north of 7,000 EMTs and paramedics. People who have left the business, people who have left the state, people who have retired, people who left during the pandemic and never came back. Just attrition. And people are not going to classes as fast as they used to, and we're not being able to put the numbers back in. So there's a finite labor pool in the state. The pandemic accelerated that, where people chose their safety over, working in public safety, and they stepped away from the industry, and some of them haven't come back. There were also some training programs that were run during the pandemic that allowed EMTs to go to class and come out having not necessarily been in-person classes. A study was done, or actually the state reported this in their findings. And between 2018 and 22, about 70% of the people that went through those accelerated programs ended up being one and done. So they came into the industry, they were in for 2 years, and then they didn't renew their certifications and left. So on top of that, we had the attrition, people like myself who've aged out. I mean, I don't practice anymore. So even though I hold a license in the state of Connecticut as a paramedic, I'm not on the road. So, that's another body that's not unable to perform and help the system. So it's important to understand that there's a labor crisis, which is being exacerbated in many areas of the state because of what's going on with the hospitals. The hospitals are entering the ambulance industry because they can't get commercial providers or volunteer nonprofit providers to do all the work that they need done. Yale, L&M, put on 2 ambulances. They're only able to staff 1 because they have a labor problem as well in getting people, and they have to staff the emergency paramedics. So they have an ambulance. Hartford Healthcare acquired American Ambulance in Norwich, which is great for Hartford Healthcare and Bacchus in their facilities around the state. Not so much when it comes to moving patients for Yale, L&M. They're not as available as they used to be, which is why Yale put on a truck. Middlesex Hospital has greatly expanded their EMS organization to the point where they now have, between medic units and ambulances, they have 20 units that they have to try and staff. So what is happening, and this is even worse in the greater Hartford and greater New Haven area, what's happening is Groton Ambulance, Mystic River, North Stonington, all of those other smaller towns are competing for personnel against folks who are now paying hospital wages and benefits, and being enticed to go up there for those jobs. So Groton was in fact paying significantly under the regional market wage scale until just recently, and we'll talk about that in a minute. And they've adjusted that to bring themselves up to average within the industry, within the region, to be competitive and to keep people, so that the trucks are in service. So part of the issue is payroll and personnel, and being competitive, and that costs money. The second is that funding from governmental insurances, Medicare, Medicaid, TRICARE, really have not kept up with the growing cost of service. Medicaid did do an increase this year, and brought the the reimbursement up to a reasonable level, still below what it should be, but they've at least, it's going to impact positively next year when there's a full year of budget revenue to be collected. Medicare is only going up 2%. And the state of Connecticut has decided this year not to raise the retail rate. Do not know how they got to this calculation, but they determined that the retail rate should not go up. With the cost of everything, they did not issue anybody an increase unless that agency went through this very lengthy financial process. Unfortunately, the state only gave agencies 30 days to comply with it, which most agencies were not ready for. So most of them are not getting an increase to the retail rate for 2025. Unfortunately, that's unfortunate. So the cost of readiness is there. The increase, in operating expenses are up, and the reimbursement's not keeping up. So on top of all of what I just said, and if there's any questions about the reimbursement side of that at this point, please ask. Anybody?
So you go to somebody's house, don't have insurance, they don't provide you their insurance, whatever the case may be. You have their address, have their name. You send a bill to them.
Our billing company does. And if they don't pay, then it goes to collections. But when it goes to medical collection, it doesn't affect their credit rating.
So if they never pay.
So if they never pay, it's really has no effect on them. And a lot of the people that we go to that are considered self-pay, we never see a dime from them.
No, they back saying we call bad debt quite often. We have to do it.
I didn't hear that comment. I'm sorry.
I don't want to take away from us.
No, I mean, I just want a clear understanding, so when I get asked, like, why do they not go after people who don't pay? It just goes to collections. If there's no consequences for not paying that, and stay in collections for their entire life. And
We have right now currently over $1 million in collections. So we are not like any other normal business in Groton. Because if you go to McDonald's and order a Big Mac, you have to pay for it before you get it. We provide the service first, and then we try to get paid after.
The other part of that is the revenue of the trips that go over and are sent over to collection. The collection, if you're lucky, you'll get about 10 cents on the dollar. And that's been a kind of a standard for years. It's small compared to the hospital bill and some of the other things. It's considered, it's a relatively small medical bill. It's big for the agencies at, $1,000 or $1,200, but in the course of collections, it's not. And so collection agencies, there's a couple that specialize in ambulance and they work the cases relatively well, and they might get 12%. But for the most part, 6 to 8 and 10, if you're really lucky, is about what happens on the retail value of what's sent over to a collection agency. And Chet's exactly right. Unlike any other business where if you had somebody who owed you a lot of money, you can shut them off and refuse to provide them service, the ambulance industry does not have that option. If they call 10 times in a day, you got to respond to them 10 times in a day. And if you take them to the hospital, they get discharged, come home, don't feel well, didn't take their medication, and want to go back in the evening, and they don't have insurance for the first trip, they're not going to have insurance for the second trip, you still got to take them. So that comes down to cost of readiness, and that comes down to the subsidy amount, which is making up for uncompensated care, uncompleted trips, and helping make the ambulance system whole. And as you'll see, the formula doesn't look at, making them profitable in the traditional business sense. It gets them to a point of breaking even based on a budget everybody agrees on. So that is the reason that you're coming. That's one of the reasons that people are coming to you. The second thing that applies to this, which is another layer of this, is first of all, you don't know if you're going to get paid for the trip. Second is it's called the payer mix, and that is who's calling the ambulance. So if you have a bunch of people who call who have Blue Cross, Blue Shield, Connecticut, you're going to get more money for those private insurance patients. If you have a higher volume of Medicare, Medicaid, and TRICARE, those trips are all significantly discounted because they're government payers, and they fix their own rates regardless of what the state of Connecticut says the retail rate should be. That makes sense? And you'll see what Groton's numbers look like in a minute. The third thing, and I'm not going to belabor this one, but the third kind of perfect storm piece is the fact that there's inflation and supply chain issues. Right now, there's IV supplies, sterile water supplies, medications that you can't get or they're on delay. If anybody in the room ordered an ambulance today, a new ambulance, you're not going to see it for almost 2 years. There's a supply chain issue that has never been fixed because during the pandemic, the ambulance manufacturers laid off some of their people who found other jobs. And because it was an import problem with chips and they couldn't deliver the ambulances. Now that they have fixed that and they have chassis, they don't have enough qualified builders to keep up with the demand. So it takes a long time. One of the services in Connecticut just got twin ambulances. It took them 2.5 years to get them. So we have increased operating costs because the agencies are trying to hold their fleets together. And then, try to get the ambulances in there. But everything else has gone up. Insurance has gone up. Obviously, payroll's gone up. Supplies have gone up, gas, everything. So one of my clients in Connecticut they'll take an order for you now. So if you place an order today, they'll take an order for the ambulance. They'll tell you the price as of today is going to be $200,000 for the ambulance, let's just say. But they don't guarantee that number because they don't know what their supplies are going to be. They don't know what the cost of aluminum is going to be, any of that stuff. They just know that you have a place in line and you've ordered a truck. One of my clients was just notified that their truck, after almost a year, the truck is now on the assembly line to be built. No delivery date guaranteed. The current price is $30,000 more than what they signed on to a year ago when they placed the order. And the question was, do you still want it? And they said, of course we still want it. And now you can place an order for an ambulance with if you want to walk away from it down the road, you can, because they know they can sell it in 10 minutes to somebody else because there's a shortage. But they also know that the price is going to go up. And in this case, that's exactly what the numbers were. The original quote was for $205,000. The new quote is $235,000 and the truck's not delivered yet. So that's what the industries are facing. They don't know how they're getting paid, how much they're getting paid, and in some cases, they don't know what their costs are going to be going forward. So some backstopping from the communities is why we're here and having this conversation. But I needed you guys to all understand that because your colleagues are going to ask. They always do. So on page 4, this is kind of an overview that you can share of what I just talked about. There's nothing else that needs to go into explaining this page, but it is the background of the information that I just gave you for the benefit of the people who may not be here to listen to this. But I want you to see on page 5 talks about the fact that if you are, regardless of the number of calls, you have to have a billable event. A billable event is a completed call. And then there's allowables. So what happens is, by virtue of participating in the Medicare and the Medicaid and the TRICARE plan, every ambulance provider and every hospital says, okay, here's our retail rate. The provider then says, well, this is the maximum you're going to get from us. And in order to participate in the program, you have to agree that the maximum allowable rate from them is what you will accept for your service. And the variant is called a contractual allowance, and you have to write it off. And you'll see what it looks like for both Groton and Mystic, because they're basically the same rates, in a minute. But it's money that the ambulance service has to write off in order to participate with Medicare and Medicaid and TRICARE, and it cannot go after the patient for the delta. So in Groton's case, 80% of the transports that they do are in fact government payers. So Medicare, Medicaid, TRICARE. So then there's a percentage that are self-pay, they have no insurance. And then the rest are commercial insurance. So the Blue Crosses and the Connecticut's and motor vehicle accidents and things like that. Those pay very close to the full retail price that the agency was given by the state. The remaining 80% are significantly discounted. And if you look at page 6, you'll see exactly how discounted they are. So if we look at the second column, that it says 2024 state authorized rate of $920. Everybody see that? Okay. That's the rate that the state of Connecticut set for Groton Ambulance for 2024. It will be the same price for 2025 because nobody got an increase. So you bill out $920. Mileage down a little further down that column went from the point of pickup, so the person's house, the accident scene, whatever it is, to the hospital. It's the number of miles times that number gets added to the 920, and that's how you get to the bill. So in that category, 15% of the patients that are picked up are private insurance, so pay relatively close to full price. 5% are private pay, may pay full price, may be in that go to collection because we have no insurance and I have no intention. I was visiting, I was on 95. I'm never coming back to Groton. I'm not paying it. And they may or may not see any money on that. So now let's go over to the first of the green columns, or greenish colored shaded columns. So the predominant number of calls that Groton does are basic life support, BLS. So on a $920 bill, a Medicare patient, which is 70% of Groton's volume, $472.94 is the maximum allowed amount that Groton can collect on that trip because of participating in the Medicare system. To further complicate this, Medicare pays 80% of that allowable rate. So the only guaranteed money that Groton has, and Mystic is the same boat, on that trip, on a $920 retail bill, is that $378.35, 80% of the allowable amount. The 20% that's left over to make the $472 is either a patient's supplemental insurance out of the patient's pocket, or if they have one particular type of Medicare plan, which is called an Advantage plan, the Advantage plan would pay the whole $472. But for argument's sake, $472 is as much as they're going to get on that patient. The difference between $472 and $920 is a contractually obligated write-off that they cannot bill by law to the patient. So when we talk about cost of readiness for 6,000 calls, completion of 4,200 plus calls, and then apply the payer mix specific to Mystic, you can see where the revenue starts to have some problems in keeping up with the expenses. And then Medicaid, which is the very last column on the chart, $920 is the retail charge. Medicaid just went up to $352.70, and that's it. So on every patient that has Medicaid, $352.70 is as much as Groton Ambulance or Mystic River is going to get. The difference between that and $920, contractually obligated by law write-off. So again, in Groton's case, that's 80% of the volume is in those two categories and has been consistently, for several years. So that's why it's important to understand the economics and the mechanics of how these guys get paid, so you know why you're supplementing them. Because those are the patients, those are your constituents, those are your taxpayers that are calling the ambulances, but have insurance that doesn't cover the costs. Everybody good with that? At least understanding it?
May I ask a couple questions?
Anything you want.
BLS, what does BLS and ALS stand for?
Basic life support are the EMT level that Mystic River and Groton Ambulance provide. Advanced life support is the calls that they do with the hospital paramedics. And the hospital paramedics, they do something called bundle billing, where they bill certain of the calls together. So you take the ambulance's rates and you take the state assigned rate that the hospital has or the paramedic service has, bundle them together, and then bill them to the insurance. And then there's a contract that they both have, and a portion of the revenue that's collected that belongs to the paramedic portion. So the difference between the basic call and the ALS call goes to the hospital. So for example, very common one, $2,018 is the combined charge for ALS 1, which is the 99% of all of the ALS calls fall into the ALS 1 bucket. Go to the 70% Medicare patient. The Medicare patient, the second shaded column, ALS 1, on a $2,018 bill, $561 is as much as the combined two services have to split. And most of the contracts, and Chet, correct me if I'm wrong in your case, your contract with the hospital, you take the BLS portion that you would have gotten and the hospital gets the difference. Is that correct?
That's correct.
So-
Only on the amount that we collect.
So when
Hold on one
the
second.
hospital provides care to a patient in the back of Groton Ambulance, the bill goes to Medicare. In this case, we use that as the example, for $2,018. Medicare says the most you're going to get is $561, of which that 80% is the $449. Right? Everybody see that? So what happens is Groton takes its $378. The difference between the $378 and the $449 is the part that goes to the hospital, which doesn't cover the paramedic service either. But it's something that the hospital, it goes to them to help absorb the paramedic cost.
Here's what you said there. So 449.30, 378 is 449.30 is the maximum amount to bill. 378.35 goes to the ambulance association. And you said something that I missed.
The rest of that.
The difference goes to the hospital.
Thank you.
So we operate, both services operate BLS services. And the paramedics are employed by Yale New Haven. And they have the responsibility or the PSA for advanced life care. We get a call, the dispatcher has protocols that they look up by what the caller is telling them. They determine whether by those calls, by those answers, whether it's an ALS call or a BLS call. And those questions and answers have been approved by the emergency medical director at Yale Hospital. Once somebody gets there, if Rob and I are the crew, we get there, we can cancel the paramedic on the radio. They don't bill. If the patient requires advanced life support, the paramedic would get on our ambulance, provide advanced life support, and we would transport together to the hospital. Medicare and Medicaid and insurance companies don't allow for separate billing. So if you're the patient, you can't get a bill from Groton Ambulance and then get a bill from Lawrence and Memorial Hospital for the same trip. So what we do is we have an agreement with the hospital that we will bill at the advanced life support rate. Whatever we get from that, we will pay L&M the difference, because if the ALS rate is, just for ease of operation, is $200 more, we pay the hospital that $200 for that paramedic to ride in on that emergency call.
That makes sense. Well, we have a pause.
It is a lot of information, but it's something that we present every year to the council when we present our budget or our budget requests. And it's more of an education for the council and the RTM, because people view us as a business and they think, well, if you're not profitable, then you should become profitable. We have barriers in our way that don't allow us to be profitable. We can't do non-emergency calls. For instance, if John Doe is living at a skilled nursing facility and he has a doctor's appointment and he's not ambulatory, we have the means of our ambulance to pick John Doe up, take him to his doctor's appointment, bill his insurance company, and bring him back. The law doesn't allow for us to do that because we are an emergency medical service. And the only way we can get patients is if they call 911. So we are kind of in a limited market. I will say we as Groton Ambulance have noticed that there is less and less commercial ambulance service available in southeastern Connecticut. I field calls all the time. Can you pick my mom up from this nursing home and take her to the... No, I'd love to help you. Well, the nurses at the nursing home, they have somebody who has abnormal lab values. So the doctor who is assigned to that nursing home says that patient needs to be seen at the hospital for further treatment. They call up a commercial ambulance service, whether it be American, AMR, Hunter's Ambulance. There's a bunch of them, but none of them are really located in southeastern Connecticut. They'll give them the nurse, yeah, we'll get there tomorrow at 1900 hours, 7 o'clock at night. Well, it's 3 o'clock in the afternoon now. I have the doctor telling me that this patient needs to be seen. Okay, never mind, thank you. They hang up, they call 911. We get dispatched for a patient with abnormal lab values. By law, we can't say this is an emergency. Once they activate 911, by law, we're required to pick up that patient.
Yep.
The only saving grace for us is we are legally only allowed to transport to an emergency room. So if John Doe needs to go to his doctor's, he's going to the hospital first and then to his doctor.
Yep.
So we, as Groton Ambulance, and I think Mr. River has also, we've seen a large uptick in our call volume. And it doesn't matter that this could be a commercial call that would be billed at the full amount, but because we were dispatched via 911, we get the reduced rate. So in the end, it actually saves the insurance companies money. It doesn't help our bottom line, but it helps the insurance companies. And it takes away our resources that we could have, and I don't want to say they're not true emergencies, but they are kind of circumventing the way the system is designed. So from an ambulance provider standpoint, our call volume has increased, but our revenue has not increased.
So
And
somebody calls you for transport, you get there, indeed, it's really not an emergency, don't look, unless they refuse it.
I've been called at 2:00 in the morning for an ingrown toenail.
We brought you Chalet for this.
And,
Yeah.
and I think one of the important things to realize is my ambulance crews have no idea what this chart says. Regardless of if somebody has the best gold plan there is out there, or if they have no insurance at all, that's where I get my gray hairs. They do the same patient care regardless of the amount of insurance or presence of insurance at all. Their job is to worry about the patient. My job is to worry about the reimbursement and getting paid for it. Some of these I can have, they have private insurance, but I won't see a return on that call 6, 8, 9 months down the road, because during that time, my billing company is sending it to the insurance company, and the insurance company says, well, no, that person didn't have coverage at the time, so it was this insurance company. So it bounces around, and I'm still sitting here going, I have bills to pay, and I haven't received any money for it. So that's, in a nutshell, one of the main reasons why we come to the town and ask for a subsidy, because inherently, the system is broken. We don't have the means to answer 6,000 calls, 7,000 calls, unless we get some subsidy from the town, because we have to wait 6, 8 months for a return on that one call. And that one patient, we've been to that house 3 or 4 times in a day. And we've taken them to the hospital 3 or 4 times in a day. They just keep going back. And we have to, by law, provide them the same level of care at the first call as we do on the 4th call. Because as soon as one of my employees says, oh, it's Mrs. Jones, we always go to, they're gonna go there and she's gonna be in respiratory arrest. It happens all the time. So we drill into our employees, and I'm sure Mystic River does too, every call is an emergency. Once you get there, you don't have to drive with lights and sirens. You don't have to put your life at risk if you know the patient is stable. That's one of the reasons why we don't drive lights and sirens at every call, because the questions are answered by the dispatch. Oh, you have a hangnail? Well, how long has this happened? Oh, it's been going on for 3 weeks. Now, in the back of our mind, we're sitting going, why did you pick 2:00 in the morning to call? But we don't say that to the patients. We treat them as a medical emergency, because to them, it is an emergency. They call 911, they're having a bad day, we're there to provide care.
Jumping into a different direction, Medicare, Medicaid rate has, you said there's a contractually obligated write-off. That is set by the federal government.
Bob?
couldn't hear the whole question.
So, there's the contractually obligated write-off for Medicare, Medicaid, TRICARE, probably any insurance, I'm assuming. Who sets that rate? Like, who gets to say TRICARE can only
TRICARE,
charge?
for TRICARE, Humana, and I'm sorry, for Eastern Region, which is us, Humana. Because whoever is facilitating that government aid contract.
Okay, so that is a government contract well above anything that, but who approves that? Like,
Human Services.
I'm sorry, one more time.
Help.
Health and-
Health and Human Services for Medicare CMS, Center for Medicare and Medicaid Services. So Medicare is applicable to all seniors over 65. And Medicaid is obviously income driven. It's administered by the state. It's partially funded by federal government and partially funded by state dollars. The state has some say over the rates, which is why they were able to raise them. But they have to justify to the federal government what it is they're doing and how they're doing it. And then TRICARE is administered through for the military. And it also pays at the Medicare rate right now. So they kind of mirror in lockstep each other. TRICARE didn't do a raise for a couple of years, but now they're pretty much in sync. So, but there's no control from the ambulance industry. Center for Medicare and Medicaid Services does have what they call open door forums, typically quarterly, where the ambulance industry can come in and say what it has to say and scream and yell a little bit. And they go, thank you very much. We appreciate it. We'll take it under advisement, and nothing happens. But so the industry does not have a lot of say until it gets to Congress, and Congress administers more, decides to up the rates or give more money. They've been doing a cost study for 3 years now, trying to get information on the industry to figure out whether they're overpaying or underpaying. I don't hold out a lot of hope because it's taken 3 years. The last time they did it, about 6 years ago, it took them 2 years to do it. They came out with findings that said, yep, we are underfunded, underpaying the ambulance industry. And their answer to that was to drop it 2%. That is physically what happened 6 years ago. And we've been making up ground ever since. So we are where we are. It is broken. Chet's absolutely perfect description. And everybody's afraid of how they can fix it because with the age-old question is, where's the money going to come from? As far as Medicare and Medicaid is concerned, the funding to bolster the system is going to come from the users, i.e. taxpayers in the community where they're served. That's been their kind of standard approach.
More questions.
So, yeah.
Important. We obviously live in a high military community where people, but we still have people who have private insurance. Are there communities in Connecticut that basically break even? That they don't need to go to their municipality to ask for additional?
There are communities that don't get subsidies. Most of those communities are much smaller volume, or have much more lucrative demographics.
Probably more private pay. Like with our insurance.
Thank you.
We good on how the money flow works and the kind of the doom and gloom that I brought to the room?
Nothing like some
I often say I should be wearing a black armband when I have these presentations, but this is not a Groton and Mystic issue. This is a statewide issue. This is a national issue. I have clients in multiple states that have this exact same issue, down to personnel and things like that. So this is absolutely not, you're not alone in this. What is the right formula or what is the right amount of funding? The good news is you're having a conversation, and the conversation that you're being asked to contribute is a portion of the budget. There are communities that are being asked. Windsor, for example, we ended up doing a study for them, and their contribution to the ambulance is more than $600,000 a year. Plus, they are partially funding a capital improvement program of over $1 million over 5 years. So, and their volume is relatively similar to Groton Ambulance's volume. They do provide the paramedic service in the community, but the town council there, we did the same thing for them, showed them the numbers and what have you, and they approved about a $1.6 million over 5 years. to do equipment upgrades, ambulance upgrades, personnel, payroll upgrades. But the ongoing subsidy is going to be at least $600,000 a year going forward. So the ultimate goal of all of this discussion is to figure out a way to at least kind of have a sense of where we're going and for both sides to get a sense of getting their arms around how we calculate what the subsidy ought to be. And there's, as we talked, there's a number of ways you do it, but kind of per capita, you can do it, just kind of throw a dart at the wall and that's approximately what we need. I don't like either one of those approaches because it doesn't take into account the true factor of what the ambulances are doing, the call volumes that may be rising or shrinking, the revenue that may be rising or shrinking. And so the formula that I'm proposing for your consideration starts with this year's current budget as kind of the bedrock that we build from, because you've already seen it, you've already approved it, you've already subsidized based on that. So it gives us a good starting spot to apply the formula and going forth in the next year and the years beyond. So for this year, for example, the budget was presented. The subsidy amount is $300,000. So $208,000 of that was turned out to be the shortfall when we apply this formula to it. And the other 92,000 allowed for the market adjustment to retain people so that the ambulances could continue to respond at the level that they were responding. So it all went into operations. It all went into support of the organization to be able to provide services to the citizens. So to use the formula, and it's in the very last third of page 7, there are some metrics that we need to know. One is the cost per transport. So what does it cost us to go out there and then complete those calls? And then from a transparency perspective, which the town should expect transparency from any vendor in this regard, what kind of revenue is the ambulance service generating? Where's it coming from? So you know that you're only subsidizing the make whole portion, not just some made up number. So the Groton ambulance budget for this current year was literally just over $2 million. So the formula works like this. You put in the budget number, the unsubsidized budget number. So $2 million divided by 4,200 transports, as you can see, $472 per transport. So budget divided by completions equals the cost per transport. Now, from Groton's perspective, from the billing side, here's the information they give you back. Here's approximately what we're going to bring in for the year. Our pro forma from the billing service, based on this call volume at the rates that we're doing with the payer mix we have, approximately $1.8 million will come in. And at this point, we're just about 1.4, a little under, but with months to go. Divided by the same number of transports equal $423 of revenue per transport. That leaves a shortfall, right? Shortfall, $34 and change, rounded to 35. You take the budget divided by the actual number of requests to get to the amount needed to make the ambulance service whole. Does that make sense to everybody? In the case of Mystic River, because they provide services to 2 towns, the proposed way that I would approach them, and they're hearing this for the first time, so if Todd falls over or tries to shoot me, but the way that would be fair to apply this same philosophy to Mystic River would be to take Mystic River's budget, to take the percentage of transports in Groton, and to take a percentage of the budget equal. So if they did, let's just use round numbers. If they did, their budget was $2 million and they did 3,000 calls, 1,500 of them in Groton, you take half the budget, you take half the calls, and you apply the formula to get to the subsidy for them. Now, I have not taken their budget number nor the numbers I got from their billing vendor this afternoon to see if how this plays out with the current subsidy, and I need to do that so that we can test the formula to make sure that it works fairly for both agencies. So I'll put the disclaimer in. Todd, does that make sense to you?
It does, and the percentage is about right. We are running about, I think we were 51% this year.
So if we take your budget and we took 51% of your budget, applied it to the number of transports done in Groton, we would get cost per transport in Groton, cost per transport, the revenue that came in from those calls. And then if we apply it to the total number of requests, not just transports, we would come up with a subsidy number. And if we do that formula back out, that would come out to the subsidy that would be fair for Mr. River. So,
So, sorry, we're taking this $35 per request times the number of transports to get the number,
No, that's a number of requests,
times the number of requests.
the amount of more calls.
Because there are of those, so
Was it,
that's where the deficit.
you're subsidizing the cost of readiness to bring them whole on their budget.
so it'd be like 35 times 6,000
Correct.
you're looking at, which actually is considerably lower than what we've been paying you.
Right. But we've also used the 92,000 to increase our wages, so that we have that readiness and the staff.
So that is not worked into this, like staffing costs and staff increases are not worked into this.
Correct me if I'm wrong, Bob, but I don't believe that town subsidy is part of your formula.
That's correct.
Right.
Okay. So really what we need to take is town, or the $2,008,000 minus $300,000.
No.
Oh,
Plus,
your full budget is $2,008,000, correct?
no,
The unsubsidized budget is $2,808,000. The actual cost of operating the service was 2.3.
So 2.308 total budget.
yes,
Okay.
You gave them, without the formula, you agreed to $300,000 for this year. And if I look at Chet's budget that his board has, it shows an influx of $300,000 from the town for subsidization. 208 of it is cost of readiness. There was and with the revenue that came in, which was slightly higher than anticipated, but not by much. And then there was $92,000 that was in that amount given to the town that was then appropriately utilized for half the year to subsidize an increase to keep people. Going forward, next year's budget is going to have a full year of those wages. So the subsidized budget next year will have been increased to about probably 2.2, 2.3. And I don't want to speak for Chet because he hasn't finished his budget yet, but it's going to go up just to cover the cost of the $4 an hour raise that people got in order to be market competitive. The difference is you're going to have a somewhat of an increase in revenue because Medicare went up 2% and Medicaid went up to that 350. Groton only saw part of a year of that. They didn't see very much of it. It was done in July. So
I want to project this into what this would have cost this year had we used this program. Can we do that?
yeah. Yeah, okay.
And then the same with Mr. Griver. Had we used this last year, how much does that number look like? And then what projected approximately, we're not going to hold you to it exactly, but what does that look like for the following year?
Yeah, we can do that.
Idea of like what this really looks like in numbers, dollars and cents. Yours?
of course.
We'll bring that back to the next meeting.
Yeah.
And using the formula, so I can tell you now, if you take that formula, it's going to be roughly 2.15 somewhere in that ballpark, if you were to apply a full year's worth of the wage differential. So it's going to be in that, the revenue is still the same. So you're going to be jumping up probably closer to $50 or $60 a call, which is going to get us into mid threes, I think. So it's going to be right there. And then the annual get together at budget season would be submission of a budget, difference in any variances between the core budget from the year before and the new budget as suggested, and explanations for those. Shouldn't take long to do. And then application of this formula, which can be submitted with the budget request. And then each agency has the ability to put that through, and then you know the number that you're working with or being asked to work with.
I'm just. Yeah, let's do that. Hand up. Do you guys have any other questions? With this?
So what we're doing,
Bob,
really,
Did you get everything you needed?
I'm going to give you a call tomorrow. I need one more piece.
what we're really doing here is showing you how everything breaks down by cost, so that when we do come budget time, everybody will know, like, you guys will know how we got these numbers. It's not just gonna be, oh, they want us to pay $60 a call. No, there's actually a reason why. And in 2 years, when I'm not sitting here or Todd is not sitting here, you guys, whoever's sitting at these chairs, understands where those numbers came from. I mean, each organization has a different operating strategy. We have different demographics for payers. We have different amount of nursing homes that we service versus regular people. We're trying to make this formula universal for both organizations, so that the council and the RTM don't have to sit through 45 minutes of me educating every single person on how the ambulance industry works. So it's kind of streamlining the budget process for both organizations.
The other part of this is it works fairly for both sides of this, both the town and for the agency. The agency is going to have increasing costs. There's no question about it. But if revenue ticks up, if the federal government changes the rates, if the state changes the rates, and more revenue comes in against that call volume, it actually benefits, and the subsidy could go down. But at least clearly both sides know what it is they're dealing with, and there's no smoke and mirrors. It gets adjusted annually based on, here's where our operating costs went, here's where our revenue is going. And it's fair to both sides because it's based on the revenue and the cost to do by the number of transports, unless the system changes its formula. And then you're subsidizing for the cost of readiness and that uncompensated care, the lift assists and all that sort of stuff, which is serving your constituents. So I think the justification to your taxpayers and the justification to the rest of your constituents on the council and the RTM, I think that's something that they can at least see, that there's transparency on both sides. So that's why I suggest this particular model.
Thank you for putting this all together. Look this. Questions?
The date for next month.
Tuesdays at 4:30 work for everybody?
As long as I'm. Has the council tasked you with coming back by a certain date?
We met on the 19th at 4:30. Work for everybody? We do it in an hour.
I can't hear you, I'm sorry.
I'm sorry, if we met on the 19th of November, we would need to be done by 5:30 because there's another meeting after this. Would that be possible? 4:30 to 5:30?
If the material was provided ahead of time, speed up on or Tuesday.
Is that possible that we get the information, Bob, beforehand? Could we get the numbers and information beforehand?
Yes.
We're gonna say Tuesday, November 19th at 4:30. Right, with that, I will take a motion to adjourn. Motion made by Councilor Pacino, seconded by Councilor Merritt. Say it out loud, so it's definitely in the record. And we are adjourned at 5:37. Thank you, everyone. Next meeting is November 19th.
Thanks, Bob.